So I thought before Christina introduces our speaker today for Grand Rounds, that I would read a poem by Mary Oliver. And for those of you that don't know Mary, this is an American poet, and she received both the National Book Award and the Pulitzer Prize, and many people have described her as being maybe far and away the country's best poet, and certainly the country's best-selling poet. So, and for those of you that write poetry, you know you don't sell many books of poetry. So this poem is called The Journey. One day you finally knew what you had to do and began, though the voices around you kept shouting their bad advice. Though the whole house began to tremble and you felt the old tug at your ankles. Mend my life, each voice cried, but you didn't stop. You knew what you had to do. Through the wind prayed with its stiff fingers at the very foundations. Through their melancholy was terrible. It was already late enough, and a wild night, and the road full of fallen branches and stones. But little by little, as you left their voices behind, the stars began to burn through the sheets of clouds, and there was a new voice, which you slowly recognized as your own, that kept you company as you strode deeper and deeper into the world, determined to do the only thing you could do, determined to save the only life you could save. So that's The Journey by Mary Jane Oliver. And so for those of you that like humanities, she's a great poet to read, and I'm going to turn it over to Dr. Wilson. We are looking for volunteers to do humanities just for a minute or two, or songs. Gary's done some songs, Cherie passed, we've heard some poems, Mike Jaffe read my Angelo. So we're looking for some humanities to mix it up a little bit at the beginning of Grand Rounds. So Dr. Wilson.
Thanks, Mike. That was great. So everybody, please join me in welcoming Gabe Bonnell, not just as our Grand Round speaker today, but also as one of our newest faculty members of the Department of Neurology. Dr. Bonnell did his training up at the Medical College of Wisconsin after having originally started his residency at MUSC, then followed his fiance up to the cold state of Wisconsin, and now is joining us to much more climate weather here in the state of Florida. So he is joining us as stroke faculty, and that is part of his lecture that he's going to be giving today about stroke and pregnancy. But he also, prior to fellowship, did some work as a neurohospitalist, which he's continuing here. So you'll see him on the general service as well. And for those of you who haven't had the pleasure yet of working with him, you'll undoubtedly be able to do so on one of those two services shortly. Looks like he's joining us from a busy clinic day from the background that I'm seeing. So thank you, Gabe, and I will turn it over to you.
Thank you very much. Let me, I guess, start by sharing my screen. Get the PowerPoint in here. Can you all see my PowerPoint?
Yes.
All right, let me start at the top. Probably is the best place to start from what I hear. Everyone can still see it?
Yep.
All right, well, thank you all for coming, or for at least for tuning in to this. I will spend the next hour or so talking about stroke and pregnancy, you know, how that differs from traditional strokes, and specifically, you know, what is the difference in incidence, workup, management of pregnancy-related strokes? You know, what kind of a beast is this, and do we need to approach this any differently? You know, I decided to do this because I think that in medicine, there's basically three different specialties that I think everyone is a little bit terrified of if you're not in that specialty. Neurology is obviously one, which is, I think, obvious by the amount of consults that we get. Pregnancy is a second, and then anything in the eye, ophthalmology is a third. So I figured if I could make a talk that included two of those three, then we can be about 66% of the way to being having no fear as physicians. So here we are. Here we go. So what we'll do, the outline for this today, we'll start just by defining the problem. So what is the incidence of stroke in pregnancy, and does this differ at all from just the incidence of stroke in young people or age-matched controls? After that, we'll talk a little bit about the potential causes of stroke in pregnancy. So if this is something that I can convince you is something that we need to worry about, why is this an issue? What is different about pregnancy? Past that, we'll talk a little bit about the workup for stroke in pregnancy and how does that differ. So a lot of stroke workup includes often labs and imaging and things like that. And how is that going to differ in a pregnant person versus a non-pregnant person? And then lastly, we'll talk about what you can do about it. So, what is the acute and chronic treatment of stroke in pregnancy? And then once again, how does that differ? How does that differ? So, like I said, we'll start by defining the problem. What is the incidence of stroke in pregnancy, and what do we know about that, and how it differs from just general stroke in the young. So there are very few prospective studies on the subject. So it's as you'll see, as I'm about to explain, it can be very difficult because this is such a rare condition, to follow a group of pregnant women and see how many of them have strokes. So what we end up falling back on is a lot of case control studies and some retrospective cohort studies, where we're basically looking back and trying to find get good data to tell us how big of an issue this might be. So in our little pyramid of evidence here, where meta-analyses and systematic reviews are at the top, and background information, expert opinions are at the bottom, or somewhere here in the middle, cohort studies, case control studies is basically where a lot of this is gonna come from. So to give you an example about how this can work, I need to minimize my window here. So to give you an example of how these studies are done, I'll give you an example of one of the studies that was published back about 4 years ago in 2016, which kind of aimed to answer this question for us of what is the risk of pregnancy the risk of stroke in pregnancy, especially across young people in the state of New York. So a retrospective cohort study where they utilized the Department of Health statistics. They have a database of all this information. They basically looked at all stroke admissions within the state of New York over a period of about 9 years, and looked to see how many of these were pregnant, and then how did they compare to age-matched controls. This was specifically designed to analyze the risk of stroke in pregnant women compared to non-pregnant women. And what they did find is that there does happen to be an increase in stroke risk during pregnancy, mostly in younger people, but this does kind of persist overall. And I'll show you what I mean by that. So this is from that study. This is some of the data that came out of that. So let's start just by looking at the orange line here. What we're seeing on the x-axis is age. So as we go to the right, that is patients that get older and older. And if we look on the y-axis, this is the incidence of stroke per 100,000 women over a year. So if we just look at just this kind of orangish line, first, what we see is that really, really young ages, the incidence of stroke is very, very low. Less in the ballpark of 10 per 100,000 women per year. And then, of course, we see what we expect as we get older and older. We're more likely to have strokes, and of course, this could eventually would skyrocket if this graph went further to the right, because that is when most strokes happen. But what we see when we look at this kind of bluish greenish line that's right above it, we can see that there is certainly a higher incidence of stroke in pregnant patients. So this blue line is pregnancy-associated strokes, and that same, per 100,000. And we do see that this is, almost double the risk, especially in these younger ages, less than 34. Once we get above a certain age, there's just too many non-pregnancy-associated strokes. So that is something that came out of that. So other kind of takeaways from this study that was very interesting that I think that we as stroke neurologists need to be ever vigilant for and be aware of, because we're going to see this in the data over and over again, is that only about a third of pregnancy-associated strokes actually occurred during a pregnancy itself. Another 25% or so, a little less than 25%, occurred during delivery. So a stroke actually during, the hospitalization for delivery of the baby. And then almost half, just shy of half of these strokes occurred postpartum. And that's usually defined as within 12 weeks of delivery. So not only do we need to be ever vigilant and be aware that this is an issue in pregnant women, but in recently delivered women as well, they are at a very high risk of stroke, almost the same risk while they are of stroke while being pregnant. In addition to that, some interesting things that came out of this study was that when compared to non-pregnant strokes, the pregnancy-associated stroke patients, the mothers had actually lower rates of our traditional vascular risk factors, so smoking, diabetes, hypertension. Now, this took me a second. I really had to stop and think about that when I read that before I could fully understand why that would be Why is there a population that is more likely to have strokes, but has less traditional vascular risk factors? And I think that that speaks to two things. Number one is that pregnancy itself must be a pretty strong risk factor for strokes. And number two is when you think of what you're comparing these to, the comparator here, the age-matched controls that had strokes are people who had strokes at very, very young ages. So these people are likely to have, much more likely to have these traditional stroke risk factors. So hypertension, diabetes, as well as lower rates, the pregnancy-associated strokes had lower rates of cancer, HIV, and then actually had lower mortality following stroke. So in this study, it was as high as 13% in the non-pregnancy associated strokes, but about half that, 6% in pregnancy associated strokes, presumably because these women are generally healthier than someone who is young and having a stroke for a reason other than pregnancy. Now, that's just one study. That doesn't really tell us everything we need to know, but I kind of just wanted to give you an idea of how this data is collected, that these are often retrospective studies. So there was, to come together to really try to find an answer, well, what is the actual risk here? What is the actual, incidence of pregnancy-related stroke? So there was one systematic review on this that was published back in 2017, a year after that first study that was published. And the idea was, we need to have some sort of a consensus of how much of a risk this is. So before this, the risk of stroke ranged anywhere from 1 in 100,000 to 1 in 10,000 for pregnancy-associated strokes. So both very, very low numbers, but obviously off by a factor of 10 of each other. Obviously, within the study, there were a lot of different methods of data collection, but as I mentioned, most of them are going to be, you're either looking for pregnant women in stroke registries or stroke women or strokes in pregnant registries. And that's obviously going to give you a little bit data. But they found 11 studies that were performed over about 27 years. Some of them were small, but a few regional and national studies that were, again, mostly retrospective cohort and case control studies. And what they found of this is the number that you guys will see if you're ever looking through the literature. This is the number that's kind of plastered everywhere, that when we think of strokes in pregnancy, we think of roughly 30 per 100,000 pregnancies. So this is about 3 times the rate of stroke in young adults in age-matched controls. So there's 2 different ways to think about this, of course. So we as neurologists, and specifically if you're considering working at all inpatient or in stroke neurologists or in consults, you need to realize that this is a very serious issue that is much more common in this age than non-pregnancy associated people. The other way, of course, to look at this is to say, for example, if you're, say, someone who is pregnant or is planning on becoming pregnant, I don't want you to walk away from this thinking that you're now at a very, very high risk of having a stroke. That doesn't, 30 per 100,000 does come out to be about 1 per 3,000 pregnancies. So you're more likely to not have a stroke than to have one during pregnancy. But on that, the opposite coin of that is you're more likely than not a non-pregnant person as well. So one interesting data that came out of this that I think we can see repeated from that first study is that we did have roughly equal rates of stroke pre and post delivery. So in the 40 weeks of pregnancy, about 18 per 100,000 strokes during pregnancy, and then again within about 6 weeks after that, about 14 per 100,000 strokes per pregnancy. So that is one way that we need to be ever vigilant. Not only is someone pregnant are they at a risk, but if someone's recently delivered a baby, they're also at risk of stroke. There are, obviously we think of very different stroke subtypes. Us for quote normal strokes, we always think of this as a largely ischemic problem with about 15 or so % hemorrhagic strokes and a very, very small sliver of venous sinus thromboses. These are very different than pregnancy associated strokes. So pregnant women are less, have less percentage of ischemic strokes, but about equal amounts of ischemic, hemorrhagic, and venous sinus thrombosis strokes. So these are truly, a different animal, I think, is what we're starting to see borne out in the data. So to kind of reiterate that data back to you. So this is from that meta-analysis here. On the left, you can see, antepartum and peripartum strokes in the first grouping, and then postpartum strokes in the second grouping. And you can see all the different studies that were included there. And in the rectangular boxes, you see the pooled estimate. These are those numbers I told you about: 18 per 100,000 for during pregnancy strokes, and then about 14 per 100,000 strokes or 14 strokes per 100,000 pregnancies for postpartum. So in that roughly kind of equal distribution there, slightly more in the antepartum and peripartum, but something we need to be concerned about. And then, of course, reiterating the data that I had just said, about a third of them end up being about hemorrhagic, so that's about 12 per 100,000. A third of them being ischemic, about 12 per 100,000. And then, again, almost a third of them due to venous sinus thromboses, so 9 per 100,000. So to represent that graphically for us, this is what we think of when we think of a typical distribution of stroke. So what we see, once again, that quote normal stroke that we see all the time, we see mostly ischemic strokes, somewhere in the ballpark of 85% ischemic strokes. And then, a good chunk that are hemorrhagic, so another 15% or so. And then about 1% they're due to venous sinus thrombosis. So this is a very rare thing for us to see from venous sinus thrombosis, compared to pregnancy-related stroke, which we see here on the right. You see that far less percentage-wise are due to ischemic strokes. Around a third of them are due to hemorrhagic strokes, and again, almost a third of them due to venous sinus thromboses. So this is something that some people will say, if you see a young person with a venous sinus thrombosis, as a young woman, that is pretty much a pregnancy until proven otherwise. You need to definitely be sure to check for that, because this is where it seems to be most common. So hopefully at this point we've completed our first objective of defining the problem, and I've hopefully convinced you all that stroke in pregnancy is a different beast that does have a high risk compared to age-matched controls. Now we can go into talking a little bit about why. Why would this be an issue? What are some potential causes of stroke that are unique to pregnancy? So when we think of the main contributors of stroke in pregnancy, I think of two things. I think of hypercoagulability of pregnancy and hypertensive disorders of pregnancy. So when you go through the literature, almost everything has some sort of connection. Every time someone has a stroke during a pregnancy, it ends up being connected in some way to one of these two things. So let's talk about these two one at a time. So first of all, we'll talk about hypercoagulability of pregnancy. So first of all, we'll talk about, why does this exist? Is this something that we actually need in modern society? Is there a reason for it? Or is it some vestige of the past, like the appendix or libertarian philosophies? So does it have something that we actually need today? And what I mean by that is that, it's attributed as a main cause for strokes in pregnancy, but, what does this actually mean? I think that if we were in a group right now, if we were, if this was, pre or post-COVID, or if this was a pre-COVID time and we were all, in the grand rounds room, I would ask for a show of hands here, who feels like they can, comfortably explain what hypercoagulability of pregnancy is. And I'm pretty sure I would get a room full of people with hands in their pockets, because this is something that I think we probably take for granted a lot. But very few people can really define what it means by that. So specifically, what are the actual pathophysiologic changes that result in this kind of nebulous condition of hypercoagulability of pregnancy? So let's talk about those. So why does it exist? First of all, the proposed purposes in this, well, first of all, the most important thing is to stop bleeding after delivery. So, when you think of delivery itself, I think, a lot of us have at least at some point been a part of them. We see that there's tearing, there's the baby itself going through the vaginal canal is going to cause a lot of tears, a whole lot of bleeding. And then the second is that we have this really, really hypervascular organ called the placenta, and then another organ called the uterus, and these are connected basically by a bunch of vascular structures, and we rip them apart from each other. So at this point, you can understand why it would be very, very important to not bleed out and die after this. So this is something that would be very, very easy to bleed out and die if we didn't have some mechanism to be very hypercoagulable at this time. So that's a great explanation, but it doesn't really answer the question of, why would we not just develop some sort of mechanism to say become hypercoagulable only in the third trimester of pregnancy or just in the last few weeks of pregnancy? That doesn't make a whole lot of sense to be hypercoagulable for an entire pregnancy from an evolutionary standpoint, if you really only need that at the end. Well, we need to remember that, a big part of this is to stop bleeding after a miscarriage. So, we have to remember that about 2/3 of all pregnancies do end in spontaneous miscarriage. So this is something that, most women, before they even know they're pregnant, can have a miscarriage. So we need to be able to be hypercoagulable at this time as well. So this is probably why we're hypercoagulable for a duration of a pregnancy, because this can be a risk pretty much at any time. We're not very good at, I guess, keeping a pregnancy or enduring it through the end. So. Now let's talk a little bit about why. And to understand this concept of hypercoagulability of pregnancy, we really need to understand the coagulation cascade. And I think I probably just raised the collective blood pressure of this group by about 20 and probably sent a lot of you into flashbacks of studying for step 1 and trying to understand this whole coagulation cascade. But I think that if we understand this, we can really understand what this concept is of hypercoagulability of pregnancy. And so just kind of think of this, if this is a little bit scary to you, I'm going to get you through it. This is a pregnancy talk. So kind of think of me as your doula for the coagulation cascade. And, much like a doula, I don't have a whole lot of training in this, and I'm going to act way more confident than I probably should. So when I think of the coagulation cascade, I really think about the martini glass. This to me was the best way for me to remember, the different components of the coagulation cascade. So you can kind of see my little martini glass here. You see here on the left, the left side of the actual cup is the intrinsic pathway, which has factors 12, 11, 9, 8, and then on the right side of the cup is the extrinsic pathway, which mostly is factor 7, and they converge at the top of the stem of the martini glass at factor 10, which activates 5, which activates 2, which eventually activates factor 1, which is fibrinogen, into forming a fibrin clot. So that is kind of the nuts and bolts of the coagulation cascade. So as a reminder, when we give someone warfarin, we're inhibiting factors 2, 7, 9, and 10, which we all remember from step 1. And then when, more recently, when we're giving things like the DOACs, like apixaban and rivaroxaban, we're inhibiting factor 10 or factor 2 with the bigatran. So, we're all acting on this pathway to stop the formation of clots. So remember, once we have a clot, to fully understand the coagulation cascade, you have to understand the fibrinolytic system as well. So we see kind of our little second martini glass down here on the bottom right, the shooter, if you will, that is basically the fibrinolytic system. So activation of plasminogen into plasmin, which can cause the breakdown of the fibrin clot. Over here, you see TPA is the main activator of plasminogen. So remember, TPA is not just something that exists in a bottle in the ED. This is something that is endogenous in all of our bodies to break down all the naturally occurring clots in our bodies. And of course, that is inhibited by the plasminogen activator inhibitor. So it inhibits the activation of the breakdown. So if anyone else's head hurts, you're not alone. There's a multiple step kind of issue there. But I think if you understand that, we'll understand why is this an issue. So what is hypercoagulability of pregnancy? Well, it's thought to be caused by this increase in estradiol during pregnancy and other hormonal changes as well that increase the levels of multiple clotting factors. So specifically, we see increases in factors 7, 8, 9, 10, and 12 are the most common ones that we see that are at about a range of about 150% of what they exist at in non-pregnant people. On top of that, we see those endogenous levels of TPA decrease during pregnancy, and the plasminogen activator inhibitor we see increase as well. So I'll show you what I mean by that. Going back to our little martini glasses, everything we see here in black, we see increased amounts of. So we see increase of all these clotting factors, which of course is going to go down and end up activating more thrombin, which is going to activate more fibrin into a fibrin clot. And then on top of that, we see increase of this activation inhibitor, which is going to help shut down this fibrinolytic pathway. And then on top of that, we see decreased amounts of TPA. So we have a lot of factors increase to forming a fibrin clot. And then we have an increase in some and decrease in some factors that are going to end up leading to basically less breakdown of that fibrin clot. So that, in a nutshell, is hypercoagulability of pregnancy. So if you can kind of understand what you see here, you understand why this is an issue and why this can lead to more strokes during pregnancy. So that was one of our two things. Remember, the other thing that was one of the main contributors to hypercoagulability of pregnancy was hypercoagulability of pregnancy, and the second one was the hypertensive disorders of pregnancy. So this is defined as any diagnosed hypertension that occurs during pregnancy. So this can be pre-existing hypertension. So if someone just has high blood pressure and gets pregnant. It can also include gestational hypertension, so hypertension that really just occurs during pregnancy and you never deal with it again. And then there's our old friends preeclampsia and eclampsia, which preeclampsia is that triad of hypertension and edema plus some end organ damage, which is usually measured by albuminuria to damage of the kidneys. And then if you get seizures with that, then you end up with eclampsia, which I think we've all at some point been consulted for helping manage as well. So, the question is, what is the actual risk? So if you're pregnant, you're already at a kind of an increased risk of having a stroke. What additional risk does this hypertensive disorder of pregnancy cause? So, There was one study, this was done, I believe, in 2017, but a cross-sectional study performed that looked at over 80 million hospitalizations nationally related to pregnancy this was a study published in 2012. So this is from 1994 to 2011, so about 16, 17 years. They looked at almost every admission in the country for for a pregnancy hospitalization. So it did not include delivery. So anyone who's admitted to a hospital while pregnant for some reason other than delivery. So anything from DVTs and PEs to hyperemesis gravidarum to just admission for strict bed rest. And what they found is that amongst all these admissions to the hospital, the ones that had a hypertensive disorder of pregnancy, so either just a pre-existing hypertension or a gestational hypertension or eclampsia or preeclampsia, they were 5 times as likely to have a stroke compared to people, controls that were hospitalized without a hypertensive disorder of pregnancy. So this seems to be one of the really big contributors. I mean, 5 times as likely. So that can be a little bit nerve-wracking. So not only is that an issue, but having a hypertensive disorder of pregnancy plus some other risk factor, this chart shows us what the actual risk is there. So this is a very, very busy one, and we'll take them one at a time, and I'll just start here at the top. So what this is saying is if you have a hypertensive disorder of pregnancy and congenital heart disease, then you have a rate of stroke of about 200 per 10,000. So we were measuring before, in per 100,000, we say about 30 per 100,000 for the general, but so we're looking at 200 per 10,000, which puts you at a relative risk of stroke of about 13 compared to someone who just has a hypertensive disorder of pregnancy. So as vascular neurologists, and really anyone that's ever going to be on the consult team or even just be asked about things like this, we need to be aware that not only is having a hypertensive disorder of pregnancy make you much more likely to have a stroke, but having that plus one of these other very common conditions also makes you at a very high risk of having stroke. So congenital heart disease, AFib, which is a very common thing, puts you at about 10 times the risk of a stroke compared to someone who just has a hypertensive disorder. Similarly, for migraine, lupus, sickle cell, so things that we see not infrequently are things that we should really be concerned about when we're consulted to see patients that have these conditions. So not only does this seem to be a risk during pregnancy, but there's 2 different meta-analyses that evaluated the risk of stroke after resolution of the hypertensive disorder. So someone who had a gestational hypertension or preeclampsia or eclampsia, had the baby, fixed the problem, didn't have hypertension anymore, and then followed them for about 10 years. And they found that people who had the risk, had a hypertensive disorder of pregnancy, they actually were twice as likely as age-matched controls who were pregnant but didn't have a hypertensive disorder of pregnancy to have a stroke within the next 10 years. And that is also true for, ischemic heart disease and venous thromboembolism. But this is something that, I think that this should probably be kind of in our repertoire of questions that we ask someone, especially if we see a youngish patient come in, and maybe a woman in, say, her 50s, who doesn't seem to have any real risk for stroke that we can find. We really should be asking not only like, have you had miscarriages in the past, which can be signs of like antiphospholipid and lupus and things like that, but we should also be asking, did you have a pregnancy in the past that was fine, but you had a hypertensive disorder of pregnancy? And if the answer is yes, we might be kind of starting to go chasing down the right direction for what is an etiology for a stroke. So something to be very, very aware of. So at this point, hopefully I've defined the problem for you, and hopefully you all agree with me that this is something we need to worry about. And then we talked about some of the main causes for stroke in pregnancy, and mostly being that hypercoagulability of pregnancy and hypertensive disorders of pregnancy. Now we can get a little bit into the meat and bones of this. So what can we do for it? So you're called on a patient, that is pregnant and is having some sort of focal deficit. What can we do? And this doesn't really just apply to strokes. I think that a lot of these questions this is going to answer a lot of questions for anyone who has a pregnant patient who wants to get imaging on that patient or do further workup. So now might be a good time if you're not paying attention to pay a little attention. So I think there's 3 big questions when it comes to stroke and pregnancy that we have. I think our big one is usually, what are the risks associated with a CT scan? So can I get a CT in a patient who I think might be having a stroke, or for that matter, a seizure or any other focal neurologic condition? If we do get a CT, are there any dangers associated with the use of IV contrast? And then on past that, are there any fetal dangers associated with doing an MRI in a patient? So let's start with just CT first. So there's some basic concepts we should all be aware of. Number one is that CT gives ionizing radiation. So that is the kind that is known to damage DNA, as opposed to magnetizing radiation, which is more common in MRIs. But we need to remember that the damage that the fetus is going to end up experiencing is really depends on the dose of the radiation to the actual fetus. So if you scan, say, a mother's head, fetus isn't really in the field of view of a CT scanner. So we might be a little less concerned about that. So usually what baby gets is a fraction of radiation that mom is going to be getting, particularly if you're not scanning directly, say, mom's abdomen and pelvis, where baby might be. So that's a kind of a basic concept. Another point is, even if baby does get a certain amount of radiation, it's going to be scattered radiation, because remember, if we're scanning neck or head, there's going to be some scattered radiation down into, say, the uterus, but that is considered to be less dire than direct radiation from a CT scanner. So it makes us want to ask this question to say, okay, how much is a safe amount of radiation to give a pregnant woman, or to impose on a developing fetus? And I think all of our knee-jerk reaction is to say, well, none. I can't imagine there's any amount of safe radiation to give a developing fetus. But I think what we need to remember is that we're all subject to some amount of radiation. And most people estimate on the subject. There's a lot of estimates, but most people say just during a pregnancy, from mom just living her life, sometimes going out in the sun, sometimes just being around older buildings that tend to have certain levels of radiation. Things like Grand Central Station in New York City is the classic example of there is a certain amount of radiation coming out of that building. So a developing fetus can expect to get around 1 milligray of radiation during their development, during their gestation. So to say no radiation isn't exactly the right question. I think the real question is, well, how much radiation is too much? At what point do we need to start worrying? It turns out there's a paucity of randomized trials on this. For some reason, IRBs are a little bit reticent to approve a study where you get 1,000 pregnant women and expose half of them to high levels of radiation and see what happens. Nor are there very many mothers that are willing to take part in that study. So data on this tends to be limited to observational studies. And there are two really large observational events that do provide the vast majority of the data on the subject. And those two events are the two absolutely terrible events of Hiroshima and Nagasaki. So when America back in 1945 decided to drop the atomic bombs on these two cities in Japan, Hiroshima and Nagasaki, not only did we do something terrible by killing a whole lot of people in these cities, but outside of the kind of kill radius of those bombs, there was several thousands of people who didn't die from the bomb but received radiation from it. And just by law of probabilities, several thousand of them were pregnant at the time. So that was this obviously very, very terrible event that did provide us with a lot of actually pretty good data on what is and isn't a safe amount of radiation to experience while pregnant. So a lot of studies that have kind of, longitudinal studies that have looked at outcomes in these women and compared them to controls to see what is the actual risk. So I'll give you one example. This is a study published back in the 70s, which I think is evident by the fact that it's titled Mental Retardation Following In Utero Exposure. Probably should have been Developmental Delay or Mental Handicap or something like that. But what they did is they compared the children of controls, which were basically pregnant women who lived in Hiroshima or Nagasaki but didn't happen to be in the city that day, and compared them to pregnant survivors of those bombs. To the mothers of those survivors, who were in the city at the time. And they estimated the dose of radiation that was given. I think it's a pretty easy estimate. Most people remember exactly where they were when a tragedy struck. So you know where the bomb was and they're X amount away, how much radiation is emitted. So if you're standing here, you received X amount of radiation from the bomb. So they estimated that, and then they monitored for rates of mental handicap in children following that. And what they did find is that there was only a statistically significant increase in the incidence of developmental delay or mental handicap in children or in mothers whose children received more than 500 milligray of radiation. So that seemed, that we're starting to look at the numbers and asking ourselves, well, what is an acceptable amount of radiation? And it might be somewhere in this ballpark. 500 milligram of radiation was some of the first data to come out of that. So additionally, most of the cases of mental handicap were when the conceptus was, somewhere between 6 and 15 weeks of gestation, which makes sense because when you think back to embryology, this is right when neurulation is happening, formation of the central nervous system. So it would make sense that that's where a lot of the deficits come from. So this is the data that came out of this, a very busy chart. But if you look just here at just the left, the left column here, you see the control group at the top. NIC stands for not in city, so just too far to have received any radiation. And then as we go down the list, we see differing levels of radiation. This is in rads, but I see mothers who got 0 to 9 rads, who were very far away, basically. As they got closer, who received 10 to 50 rads, 50 to 100, and more and more and more. And then over here on the fourth column here, you see what is the relative risk. So obviously the relative risk for the control group is 1, but we don't see any statistically significant increase in the rates of mental handicap until we get to about 50 rads, which is about, like I said before, 500 milligram. So there's 10 milligram a rad. So that's the conversion right there. So really, we didn't see that in these people that got between 0 and 100 milligram of radiation and 100 to 500 milligram of radiation. There wasn't a statistically significant increase here. And then Nagasaki didn't have as good a data, so that was a smaller city at the time. So most of it came from Hiroshima in this particular study. So that was one study, but once again, we don't try to hang our hat on just one study. So this is a table that came out of another meta-analysis that was done on the subject that looked at all the different kind of effects. So this is once again a very, very busy chart, but I really just want you to focus on the first and the fourth column. This first column right here is the effect being measured. So whether it was prenatal death or growth growth retardation, as they put it, organ malformation, small head size, severe mental handicaps, reduction of IQ. And then this fourth column here, this labeled human studies, is at what point was there what they call the threshold dose. So the dose at which you saw a statistically significant increase in whatever that variable on the left is. So for example, for any sort of growth retardation, we didn't see any sort of threshold, we didn't see any sort of statistically significant difference until we got to about 200 milligram of radiation. That's when we started to see that there seems to be an increase in growth retardation. Similarly, down here for things like organ malformation, about 250 milligram of radiation. For severe mental handicaps and reduction of IQ, somewhere around 100 milligram of radiation. And then there were a few like childhood cancer where there wasn't really a threshold, it was just linear. So to illustrate that, I'll show you on the next slide what I mean by that. So once again, we've got the dose that the fetus received. So the controls at the top who received 0, all the way down to 100 milligram. And if we look at the second column, what we're seeing is the rate of there being absolutely no malformation. So 96% of kids had no malformation who didn't receive any radiation, meaning about 4% of them did have some kind of malformation. So cleft lip, cleft palate, polydactyly, syndactyly, anything like that. And you can see as the dose of radiation increases, we do see that as we get down to 100 milligram of radiation, we see that number of no malformation decreases by about 0.2%. So a number needed to harm of around 500 for 1 milligram of radiation. Excuse me. Similarly, we see similar numbers for childhood cancer, and then when we combine them here on the right, this column labeled no malformation and no childhood cancer, we see that's just shy of about 96% for the control group that got 0 radiation. And then for the groups down here at the very bottom that received up to 100 milligram radiation, it drops by about 1%, only about almost 95%. So number needed to harm is about 100 right there. So for every 100 people that receive over 100 milligram of radiation during development, there's going to be some either malformation or type of childhood cancer. So those are the numbers we're starting to look at. So that's what we're thinking of as amounts of radiation that can hurt people is somewhere maybe close to 100, maybe a little less than that. How much are we giving patients when we order a CT scan on a patient? So this is another study that was done up in, I believe, in Washington State, the University of Washington. But they measured how much does radiation does a developing fetus get for different studies. So what we order up here at the top, things like a head CT, you get darn near 0 milligram of radiation that is going to make it through the body of mom to the fetus. And you can see as we get closer and closer here to the pelvis, we can do a chest CT, we get maybe a little less than 1 milligram radiation. And of course, if we're doing scanning the abdomen or even like a CT angiogram with the aorta, we're going to get, close to maybe 30 milligram of radiation. But still far below that threshold we've been seeing of maybe 100 milligram of radiation. So there are a few takeaways from this. Generally speaking, what most regulatory committees think to be a safe amount of radiation is this number of around 50 milligram of radiation, mostly because there was very few abnormalities seen at anything below 100 milligram. So I think to be safe, most committees just decided that 50 was our cutoff, to say that above that, that we might, need to be concerned, but below that, we probably shouldn't. On top of that, a head CT is thought to give less than 1 milligram of radiation. Some sources might source and say, maybe 1 or 2 milligram of radiation, but certainly far, less than 10% of that, 50 milligram cutoff that we've kind of agreed upon as a society. And then I'll talk a little bit later about CTA and CTP, but they also give, much less than 50 milligram of radiation as well. So there's a few, that's not just my opinion that's coming out of this. There's 2 different policy statements I'll quote here on whether or not you can give CTs in a pregnant woman. The first is from the National Council on Radiation Protection and Measurements, who said that the risk of abnormality is considered to be negligible at 50 milligram or less when compared to other risks of pregnancy, and the risk of malformations is significantly increased above control levels only at around 150 milligram of radiation. And then ACOG, the American College of Obstetrics and Gynecologists, so basically the AAN of OBGYN, one of the main authorities on the subject matter, said, women should be counseled that X-ray exposure from a single diagnostic procedure does not result in harmful fetal effects. Specifically, exposure to less than 50 milligram has not been associated with an increase in fetal anomalies or pregnancy loss. So I kind of saw that as pretty strong words, in a world of defensive medicine where everyone kind of hems and haws and hedges everything they say. I thought that was very definitive to say, in my interpretation of it, which is essentially, if you as a practicing neurologist have a concern for your patient who is pregnant, and you think that you will get more needed information or change management in some way with a CT scan, you should do that CT scan, which I think is very, very maybe awkward, because I think that we've all been trained that this is something that we should be wary of. But this is something that the data does not show, single procedures cause any real harm. So consider that if you feel that you need it. So going into that, if we can get a CT scan, if I've convinced you that we can get a CT scan, well, the question is, can we do iodinated contrast? This is a FDA Category B drug. There isn't any risk in animal studies, but there has been no human studies on the subject. There has been some concern, and I'm just bringing this up in case someone says it to you, for hypothyroidism. So if someone is maybe a little bit reticent to get a scan, the idea is you're giving iodine, is that going to plug up the developing thyroid and cause an issue? So in the past 30 years, 3 decades, there's been no cases of contrast-induced hypothyroidism in the literature. And that's in spite of the fact that standard practice within all of North America, so Canada, America, Mexico, and Central America, where standard practice is to test baby for hypothyroidism if mom received any iodinated contrast. And even within that, there's been no cases of that. So I think there's very low risk with iodinated contrast in an otherwise healthy pregnant woman. So when it comes to stroke and MRI, this is generally considered to be a very safe in pregnancy, mostly because, like I said earlier, MRIs are emitting magnetizing and not ionizing radiation. There are 2 theoretical risks that, again, I don't think is a concern, but I think that you should be aware of it in case you want to get an MRI on a pregnant woman who's a little bit reticent because of this. So there's been some postulation that magnetic fields in vitro have been observed to affect cell migration, and is this going to lead to any sort of developmental abnormalities? But this has not been borne out in any of the data. And of course, there's this risk of hearing damage. Anyone who's ever had an MRI knows that these are very, very loud procedures. And if the APA is saying, well, we shouldn't, give developing children any more than about 90 decibels, which is about that of the sound of a lawnmower, are we going to hurt, babies developing ears? An MRI itself can generate 80 to 120 decibels. But we have to remember that the maternal body itself can attenuate about 30 decibels of sound. So the amount that's getting to baby is going to be below that threshold that the APA is recommended. So probably no real risk there with MRI. So again, pretty definitively, the ACOG has said MR imaging is not associated with any known adverse fetal effects, and the American College of Radiology has similarly said MRI can be performed in all trimesters if deemed clinically necessary, although they do hedge a little bit and say it should be less than a 3 Tesla scanner, which I believe most of the scanners that we use for non-research patients is 3 Tesla or less. So when it comes to gadolinium contrast, this is maybe the one thing we could be a little bit maybe concerned about. This is a category C, FDA category C, or pregnancy category C drug that has shown a little bit of harm in animal studies, but I will kind of editorialize and say that mostly is at repeated supraclinical doses of gadolinium contrast. There are some small retrospective studies that haven't shown any adverse fetal outcomes with the use of gadolinium. Well, for the most part, people say to avoid it just because we don't know, unless it's very essential and would change your management. If you're concerned that someone might have a type of developing brain tumor, a grade 1 glioma, something like that, and maybe you could consider that. This, of course, is very hospital specific, whether or not you can get gadolinium contrast, so check with your hospital on that. So at this point, hopefully we've defined the problem. Hopefully I've convinced you this is an issue. This is a unique beast. We've talked about the potential causes of stroke in pregnancy, again, being hypercoagulability of pregnancy and hypertension of pregnancy. We've talked about the workup and how, for the most part, we can do most of the images we want to do when working up a stroke. We just need to be a little careful with gadolinium. So what can we actually do in the acute setting? So if you get called and if for someone who might be having an acute stroke, what can we do both in the acute and chronic setting? So in the acute setting, it still comes down to there's really just 2 main interventions that we do for acute stroke, ischemic stroke anyway. There's TPA and mechanical thrombectomy. So let's talk about these 2 in turn. First, we'll talk about TPA. So this was first approved for use in stroke patients via the NINDS trial, which was published back in 1996. And it did show an improvement in patients at 3 months who received TPA compared to those who did not. I do often hear that pregnancy was one of the exclusion criteria in the study. When I read the study, I actually don't see pregnancy as an exclusion criteria, but it certainly made no mention of a special stratification of pregnant women for this. So there haven't really been any trials that have been specifically conducted to address any efficacy or safety issues of TPA in pregnant women. It is considered a category C drug. Of course, there has been some harm in animals at, once again, supraclinical, super therapeutic doses, but some other smaller studies that showed, 1 mg per kg doses, which is what we give, to show no real fetal toxicity or any teratogenicity. One kind of point about TPA is, in a normal healthy pregnancy, it does not cross the placenta. It's a very, very large molecule. So really direct harm to the fetus shouldn't be your question in giving TPA to a pregnant woman. What it should be is, are you more likely potentially to hurt mom by giving her TPA and thus, maybe hurting the fetus secondarily? So before 2015, this was considered an absolute contraindication via the American Heart, American Stroke Association. There were several case reports of people giving TPA and doing well after that. And so they kind of re-updated their exclusion criteria in a statement back in 2015, where they referenced 12 different case reports, 8 of pregnant women getting TPA, 8 of whom ended up very healthy. 2 ended up with ICHs. Some of those ended up with fetal demise and medical abortions as well, unfortunately. But based on that data, and especially specifically those 8 that had done well, they did come up with a statement on this and saying that TPA can be considered in pregnancy when the anticipated benefits of treating a moderate or severe stroke outweigh the anticipated increased risks of uterine bleeding. So this level of recommendation is 2B, which is considered to be a weak recommendation. That level of evidence based on limited data is what LD stands for. So when it comes to giving TPA in pregnancy, I think it is something that we can consider doing, but it is something that I think that there is not strong data for, and you need to be respectful of that. And they do make a point of saying that safety and efficacy is not well established, especially in the postpartum era. So once again, we've just, someone's just delivered a baby, they have a lot of reasons to bleed. So I would say probably, if you're going to give TPA to a recently delivered baby, I would be probably talking to the on-patient gynecologist to see, is this something that amount of bleeding that they would feel comfortable managing if we did that. So, still no definitive answers here, but it is something that you can do. TPA is if you feel that is necessary. The other acute thing that we can do for ischemic strokes is mechanical thrombectomy. So this was first proven to be safe back in 2015 with 5 different studies, 3 of which pregnancy was an exclusion criteria. The other 2 made no mention of any risk stratification in pregnant patients. So, and of course, there have been no randomized controlled trials to evaluate the safety in pregnant women. So the main area of concern is, if anyone has not had a chance to see a mechanical thrombectomy, they usually go in through the femoral artery in the groin, and they use X-ray or fluoroscopy to basically thread a catheter up the aorta and into the brain where they need to go to do the thrombectomy. And the big concern here is you're doing fluoroscopy right through the belly, abdomen, pelvis. Are we going to hurt baby, give too much radiation there? So there was one study that was published. This was in England, I think in 2017. Obviously from England, you can tell by the spelling of some of the words in the title here. But the idea of this was to see, how good can we do? How little radiation can we give a developing fetus if we do everything we can to limit the amount of radiation during a thrombectomy? And they only referenced 3 cases when they did this at 3 different centers. They did a CTP and mechanical thrombectomy, and they did everything they could to limit radiation. So using monoplane fluoroscopy, they usually use biplane fluoroscopy. They put a lead shield over the uterus. The guide wire was inserted instead of by using fluoroscopy. They just did it by feel. There was no screening over the pelvis and abdomen. They took as few pictures taken, and they didn't magnify the photos. So when they magnify it, there's more radiation there. So they did everything they could to decrease the amount of radiation, and then estimated how much did baby get via different computer software. And what they found is when they did everything right, the dose of the fetal radiation that they got during a thrombectomy, that the developing fetuses got during thrombectomy, was, you can see, 0.02 microgray. So I'll remind you, this whole time I've been talking in concerns of milligray. There's 1,000 microgray and a milligray, and this is less than 1 microgray. So for all intents and purposes, if this is done right, this can, what this I think showed is this can be done to give essentially 0 radiation to baby during this procedure. One of the other things that people are talking about now is getting access through the radial artery instead of through the pelvis, and then you're probably also exposing to less radiation as well. This is the data that came out of this, and in this first column here we see the mechanical thrombectomy and how much radiation we got, far less than 1 microgray. Similarly, for a CTP that was done prior to that, once again shielding the belly and giving very, very little radiation, it seems, compared to, say, a typical trauma, which is a little bit more, but still not a whole lot. So that is acute treatment. Lastly, in our last couple of minutes, we'll talk about the secondary prevention in pregnant women. So often secondary prevention usually comes in the form of either antiplatelets or anticoagulants. These medications are not greatly studied in pregnant women, so harm to fetus is really pretty difficult to quantify. What we fall upon is, generally speaking, expert opinion. So the best maybe expert opinion or review that came out of this was back in 2017, published by the Canadian Stroke Best Practice Consensus Statement, which, despite the notable handicap of being Canadian, I think they took a break from checking maple syrup and ice fishing, and they were able to look at all the data in this and see what is the best recommendations they can make. So they basically made guidelines with the following 4 principles. The first being that maternal health is most important. So most of the time they considered what is most healthy for mom. They considered less what is healthy for baby. The idea being that, baby can't be healthy without mom being healthy. They asked themselves, what would we do if the patient wasn't pregnant, and what would we do if they didn't have a stroke? And then there are kind of 2 hedging principles of course, an interdisciplinary team should be used to address, complex decisions, and, they should be individualized, or what, this is kind of basic statements about that. But what they found is they gave a couple recommendations for different antithrombotics and antiplatelets. So aspirin first, they reference a study that was published back in 2014 called the EAGER study, which was made to look at women who had had multiple miscarriages and see, can we decrease the amount of miscarriages by giving them low-dose aspirin? They didn't find any difference in this study in decreasing the amount of miscarriages, but what they did find is that they measured a lot of the adverse outcomes in these two different groups that did and did not receive low-dose aspirin, and they didn't find any differences in pregnancy loss, birth weight, preterm birth, and preeclampsia. Additionally, there's another meta-analysis that showed that aspirin itself can be used to decrease the rates of preeclampsia when given in the second trimester. So this is something that if I understand right from reading the literature, there is still some argument back and forth of whether or not they should be giving low-dose aspirin, but this is something that is done by at least some OB-GYNs. So with that in mind, they did say that the congenital malformations, such as neural tube defects and cleft palates, with aspirin have not been shown to be significantly increased. So aspirin is something that if we feel that we need this for secondary prevention, we can't do. Obviously, there's always risks there was one study that showed an increased level of gastroschisis, so when the guts are born on the outside of the baby, but this wasn't replicated in further studies. There's always this risk of Reye syndrome, but that's never been seen in mothers taking low-dose aspirin. High-dose aspirin is another story. And then, of course, aspirin itself is an NSAID, so the concern is, are we going to prematurely close the ductus arteriosus? While this has been seen in studies for other NSAIDs like ibuprofen, this has not been seen in low-dose aspirin. So that is something we don't necessarily need to be concerned about. What the committee said is that in women for whom antiplatelet agents would be recommended, it's reasonable preconception in the first trimester and throughout the rest of pregnancy. They did say that if you're going to give an antiplatelet, you should give aspirin, not because it's proven to be safer than, say, Plavix or Brilinta, but there's just a little bit more data on aspirin. So that's kind of what we fall down to if we want an antiplatelet. When it comes to anticoagulation, the safest known anticoagulants are, I should step back and say, because a lot of these strokes are going to be due to venous sinus thromboses, if we need someone on anticoagulation, heparin and Lovenox are our two mainstays of treatment because they're large enough that they don't cross the placenta. I want to remind everyone that warfarin is a Category X drug. That does increase the rates of miscarriage and teratogenic effects, especially in the first trimester. There are some cases of thrombosis experts giving low-dose heparin to patients who, say, have a mechanical valve and low-dose warfarin to patients who have a mechanical valve and absolutely need some sort of anticoagulant. But I think that is probably beyond our skill to decide upon. And there's not really any data on the use of oral anticoagulants in pregnancy. So lastly, I want to remind everyone that statins are not only a pregnancy category X, but you can't really reliably interpret lipid levels in a pregnant woman anyway because of many hormonal changes. So really, if someone has a pre-existing diagnosis of hyperlipidemia, we mostly focus on diet during pregnancy. And lastly, because a third of these strokes are due to intracerebral hemorrhages, the mainstay of treatment there is going to be blood pressure. I want to remind everyone that ACEs and ARBs carry an increased risk of kidney injury, which can lead to less fluid around the baby with oligohydramnios. And then the first line medications are labetalol and nifedipine are what we consider. So in summary, just remember that stroke does have an increased incidence of about 30 per 100,000 pregnancies, which is increased compared to the baseline population. Remember that stroke is further increased with hypertensive disorders and other traditional risk factors. CT and MRI are most likely safe in pregnant women, particularly in the head, and if you're very careful, and the benefits probably outweigh the risks. And lastly, the benefits of aspirin or low molecular weight heparin for secondary prevention in pregnant do likely outweigh the risks, although the data isn't exactly clear on that. So I want to thank you all very much. I appreciate you all tuning in for this, and I think that we can probably open up for questions. Let me see if I can open up the chat here. Does anyone have any questions? Anyone at all? I'm trying to find the chat and let me see if I can find it in here. I'm not seeing anything on the chat. Anyone with any questions at all? Stop my screen share here. one. Thank you. You are welcome. Last chance. Does anyone have any questions?
Thanks so much for the great review, Gabe. That was great.
Yep. All right. Well, thank you all very much for tuning in, and I hope to meet those of you who haven't met yet soon.